Okay, then we are going to move to penicillin. We already mentioned about penicillins for an example. We mentioned about that. We have that the one will be ending with a tidine, cimetidine, ranitidine, famotidine, and so on. They are a histamine antagonist, usually H2 antagonists. We use them as I will show it to you, we use them to decrease the production of hydrochloric acid in the stomach. Okay, then we have sartan. We have sartan. Any drug will be ending with sartan. It is an angiotensin 2 receptor antagonist. Will be block the receptors that angiotensin 2 will be working on it. So we call it, usually that's a bad one, angiotensin receptor type 1. Type 1. However, the main difference is now they are going to block the receptors. So they are not going to block the enzyme. So they are not going now to increase the bradykinin. So the patient, if usually the patient was unable to tolerate the dry cough and so on, from the angiotensin converting enzyme inhibitors, we might be using now the antagonist for these receptors. Then we have the statin. Again, we have many drug will be ending with a statin. The statins, they will be inhibiting actually the conversion of hydroxymethylglutaryl coenzyme A to a specific substance that will be a precursor for the cholesterol. So they will prevent the production of finally will prevent the production of cholesterol. So they are an inhibitors for hydroxymethylglutaryl coenzyme A reductase. So we don't have now the production of a cholesterol. So they are going to decrease then the low density lipoprotein, the bad one. They are going to increase the high density, the good one. They are going to decrease the triglyceride. And usually this statin will decrease the mortality for someone who has a coronary artery disease. Now, one of the toxicity for statin, to remember it, they might be producing a myopathy and also hepatotoxicity. They might be producing hepatotoxicity and myopathy. Then I'm going to move to the medications that will be ending with caine. Okay, here we have all the local anesthetic agent. Usually the majority of them will be ending with caine. Because they are the natural one, it is a cocaine, and then just like we obtain the other one by modifying the structure. So all of these we obtain it in the lab. Except for cocaine, it is a natural one. Now, this local anesthetic agent will be prevent here the nerve axons. Okay, we have the action potential will be propagated along the nerve terminal. Okay, from the source of injury, they are firing more until we reach. It will be reaching to the brain, so we are able to feel it. So here the action potential propagation will be coming through a sodium channels. So these local anesthetic agent will be block these sodium channels. So that's how they will be working. Normally you have here the sodium channels. Okay, so the sodium will be getting from the higher concentration to the lower concentration, from outside to inside, and that will be activating the another sensitive voltage sensitive sodium channel, so it will be open. So by this way the action potential will be propagated. You inject or you put the local anesthetic agent beside this nerve terminal. It will be part of it will be charged, part of it will be non-charged. Okay, part of it will be charged, part of it will not be charged. So the non-ionizable form will be diffused through the cell membrane. Then again, it will be one of it will be ionized, one of it will be non-ionized. So the the ionizable form is going to bind to the sodium channels from inside, and it will block it. Okay. We have two types of this local anesthetic agent. Okay. One type, we call it an amide. Okay, amide, it will be we call I'm sorry, not this one. Okay, we call it an amide. The other one, we call it an ester. Just like to be able to differentiate, usually the amide one containing an I in their name. The ester ones, they don't contain an I. The esters, they don't contain an I. Okay, so the amide will be metabolized in the liver. The ester will be metabolized by a specific pseudocholinesterase in the plasma, and the ester one will be producing an allergic reaction because they are going to produce a para-aminobenzoic acid. Okay, that's it. Okay, the final issue that I want to mention, almost all the local anesthetic agents, they are going to produce a vasodilatation. Except the cocaine will produce vasoconstriction. Okay. Then the drug which will be ending with mycin, macrolide antibiotics. Okay, ending with mycin, erythromycin, clarithromycin, azithromycin. Now, these antibiotics, they are bacteriostatic. They will not kill the bacteria because they are going to bind to the 23R ribosomal RNA. 23 ribosomal RNA, which it is a part of the 50S ribosomal subunits. Okay, and they will be blocking the translocation. For the messenger RNA. Okay, so macro again will give you something to remember. Macrolide antibiotics. Okay, it is a macro slide. You will prevent the translocation. And they are going to inhibit cytochrome B450. Okay. However, some of the side effects for it, they are going to increase the motility. They might be producing dysrhythmia or arrhythmia, and also they might be leading to an acute cholestatic hepatitis, arrhythmia, and increase motility. And the final, I am going to talk about those who are ending with a conazole. They are, the one who are ending with a conazole or azole, they are antifungal medication. The antifungal medication, okay, in the fungus we have the cell membrane. It's containing ergosterol, essential component of the cell membrane. In our cell membrane in the human, we have cholesterol. In the fungus, we have ergosterol as a essential part of the cell membrane to function in normal. Okay, so these antifungal medications, the one who is ending with conazole or azole, they are going to block the production of ergosterol synthesis by inhibiting cytochrome B450. Okay, and have you seen any drug ending with hamdine?